Namaskar and welcome, dear viewers, to today's session of Critical Care Webinars. And today we have an international faculty lecture, and it's a great honor and privilege to welcome Professor Leo Heunks to our webinar today. He is the international faculty speaker for today's lecture. So, sir is an intensivist and pulmonologist, and he's a clinician, scientist, and he's based in Netherlands. He's head and professor, Department of Intensive Care, Medical Center, Radboud University, Netherlands. He's the chairperson elect of the Acute Respiratory Failure section of European Society of Intensive Care Medicine. He's associate editor of the American Journal of Respiratory Critical Care and member of the executive committee of PLUG, American Thoracic Society and European Respiratory Society. He has a large number of publications, more than 300, and he has recently been awarded in 2024 the European Respiratory Society Lifetime Achievement Award. So indeed remarkable, sir, and it is indeed our honor and pleasure to have you with us and to speak to us. Thank you, sir. Over to you.
Thank you very much. Thank you very much for this very kind introduction, and it's really a pleasure and honor for me to present to this group. I have been to India quite a couple of times, and as I just mentioned to the chair, I think your country is really, really impressive. Always enjoy to be there. At this moment, we're having a webinar, which is fine as well. I really feel privileged that I can present to all of you. So my title is Weaning All There Is, and that's a quite challenging title, honestly speaking, because I think weaning from mechanical ventilation is really an exciting topic, and basically we could talk about it for days. But we only have like 45 minutes, so I'm going to highlight a couple of things, a couple of new studies which I think are of clinical importance. So these are my disclosures. I don't think there's anything that is really important in relation to the current presentation. So right here, and I'm sure you're all familiar with that, is a typical trajectory of a patient in the ICU on mechanical ventilation. So initially, after endotracheal intubation, there is a shorter or longer period of controlled mechanical ventilation. And when the patient improves, I guess most of you will decide to put the patient on an assisted mode. At some points, we're ready to start weaning, maybe perform a spontaneous breathing trial, and if successful, the patient will be extubated, and if the patient fails, reintubation will follow. But if you look at this, it looks quite simple, but it's actually quite some questions here, because if I'm going to ask you, what is the appropriate timing to switch a patient from control to assisted ventilation, I'm sure that it will get a lot of different answers. And why is this such an important period? Because when we switch from controlled to an assisted ventilator mode, the most important thing that changes is that the patient will have a respiratory drive and respiratory effort. And why is this important? Because at this time, having a low respiratory drive and effort has adverse events. Patients that have a low effort are at risk to develop respiratory muscle atrophy, poor patient-ventilator interaction, and atelectasis. On the other hand, if patients are having in this period a very high effort and drive, they are at risk to develop the so-called diaphragm myotrauma, self-inflicted lung injury. High effort may have hemodynamic consequences, and a high respiratory drive is associated with dyspnea sensation. So this period in the transition from controlled to assisted ventilation is a very important landmark for the patient. And in fact, and I'll show you some evidence later on, clinicians may delay the transition from controlled to assisted ventilation, as we are sometimes worried about this self-inflicted lung injury and diaphragm myotrauma. However, on the other hand, and we may not always realize, controlled modes require a higher dose of sedatives that are associated with prolonged mechanical ventilation, prolonged admission in the ICU, and delirium. And it's interesting. We have a lot of guidelines for the ICU, but very few guidelines actually tell us what is the appropriate timing to switch from controlled to assisted ventilation. And we very recently, it's actually published, will be published shortly in the Blue Journal, conducted this trial. Great work by one of our PhD students, Carmen Reep. And what she actually did is a target trial emulation based on the wean safe data. And the target trial emulation is a statistical approach to mimic a randomized controlled trial based on observational data. And for this study, and I will discuss it in a little bit more detail later on, she used the wean safe database. And this included thousands of patients that have been on the ventilator for at least 2 days. What you wanted to investigate is the difference in outcome between early transition from controlled to assisted ventilation versus a delayed switch. So for this, we first had to define the so-called switch eligibility criteria. So what would be, if you would design an RCT, appropriate to switch a patient from a controlled to assisted mode? Well, the first thing, of course, before you can switch, the patient has to be in a controlled mode. Based on consensus, we decided that a PF ratio higher than 150 would be appropriate, and obviously patients cannot use muscle relaxants, otherwise you cannot switch to an assisted mode. Based on that, there were 2 arms. So patients in the early switch group, that were patients that switched within 1 day of meeting these criteria to an assisted mode, and delayed switch would mean patients taking more than 1 day after meeting these 3 criteria to switch to an assisted mode. So the primary outcome of this study is a little bit complicated. And first, it was the cumulative incidence of successful extubation at day 28. And secondly, it's the so-called restricted mean time lost. And that's maybe for most of you are not very familiar outcome parameter, but the RMTL, I'm sorry, there's a Dutch slide, so I'll translate it for you right here. So the RMTL of a successful extubation represents the total number of days the patients are successfully extubated within the first 28 days. So the higher this RMTL, the more days of successful extubation. So right here, first, percentage of patients successfully extubated at day 28. In the early switch group, it was 70%. In the late switch group, 63%. So early switching to assisted ventilation, a higher percentage of patients were successfully extubated at day 28. But now important, if you look at this RMTL, it will tell you that on average, patients in the early switch group spent 4 fewer days on the ventilator as compared to patients with delayed switch. So it looks like early switch is beneficial for the patients. And also if you look at secondary parameters, outcome parameters, patients in the early switch group had 7 additional days of being discharged earlier from the ICU. There was no difference in mortality, and interestingly, an early switch to assisted ventilation did not result in a higher percentage of patients that needed to be switched back to a controlled mode. In both groups, around 30%. So I think, and this is a little bit on the edge whether this is weaning or not, but I thought this is a very important message for you to consider, that an early transition from controlled to assisted ventilation reduces the duration of invasive mechanical ventilation. And I didn't really touch upon that because it's not the topic of this webinar, but I know that you've discussed this before. We have to realize we are worried about diaphragm weakness and self-inflicted lung injury, but the evidence in itself is not very strong. Okay, take a next step. If we define the start of the weaning process, and if I'm going to ask you, I think I'm going to get different answers. Some people will say, well, weaning starts at the moment of intubation. Other people will say weaning starts at the moment when we switch from, as we just discussed, controlled to an assisted mode. But in the literature, there's a kind of consensus to say that weaning starts with the first separation attempt, which in many patients is first spontaneous breathing trial. The first spontaneous breathing trial is a very important milestone in the trajectory of a patient on mechanical ventilation. So that's right here, and I guess many of you are actually doing daily spontaneous breathing, breathing trials in your patients. But if you think about it, there's still a lot of discussion. So when should we do the first spontaneous breathing trial? How should it be performed? So I think it's important to discuss this in a little bit more detail. If you think about a spontaneous breathing trial, what it actually is, it is a screening test to identify patients that are potentially ready for extubation. And if you think about what is a screening test, well, the WHO defined criteria for a screening test. And it's interesting to think about it in the perspective of a spontaneous breathing trial. A screening test is done only for diseases with serious consequences. Yes, we are looking at patients on invasive mechanical ventilation, so this is serious consequences. If an SBT is positive, the patient can be extubated. The test has benefits for the people's health. Sure, if the SBT is successful, patient can be extubated. It's in the benefit of our patients. An SBT and a screening test must be reliable and not harmful in itself. Well, I think an SBT indeed is not harmful in itself, right? I mean, we don't see any damage from either a successful or a failed SBT. And there must be an effective treatment when detected at an early stage. Yes, if the SBT fails, we just reconnect the patient to the ventilator. So, and it's important for your clinical practice to realize the SBT is a screening test. So let us get into a little bit more detail. So when do we consider a patient ready to be weaned? Well, this is a paper many years ago published in the European Respiratory Journal that defined a couple of parameters to consider a patient ready to wean. Obviously, there need to be adequate cough, no excessive secretions, and so on. But I would like to focus you on the oxygenation criteria defined here. Arterial saturation higher than 90%, on an FiO2 below 0.4, with a PF ratio higher than 150, at a PEEP equal to or lower than 8. Keep that in mind, please. So this is a study published in JAMA a couple of years ago. I would like to discuss in a little bit more detail because I think it's important. In this study, they recruited patients that were on invasive ventilation for more than 24 hours. And patients were randomized between an SBT using 30 minutes with 8 of pressure support or a much heavier SBT, 2 hours on the T-piece. So which patients were eligible to start the SBT? Well, there was a resolution of the underlying conditions, hemodynamically stable, no or low dose vasopressors, Glasgow Coma scale higher than 12, and the oxygenation criteria, SpO2 higher than 90%, at an FiO2 equal to or below 0.4, and respiratory rate lower than 35. So the primary endpoint was remaining free of invasive mechanical ventilation in the first 3 days after the first spontaneous breathing trial. And as you can see, patients that performed the heavier SBT, the 2-hour T-piece, had a lower chance as compared to patients with a pressure support SBT. So if you look at this, you would think that a 30-minute pressure support trial would be more beneficial as compared to the 2-hour SBT TPs. However, if we look at a little bit more detail, right here is shown extubation, the percentage of patients that were extubated after the first SBT. That was 93% in the patients with the 30-minute SBT and 84% in the patients that performed the 2-hour SBT. And if you think about it, if you are doing a screening test and the screening test is positive in 93% of your patients, I would say it is not necessary to do an SBT, right? It's not necessary to perform a screening test because it's positive almost always there. A screening test should be negative in many, many cases. Otherwise, it does not make sense to screen a patient. Let me get to another trial published in the New England Journal of Medicine 2 years ago, also comparing SBT strategies. Again, patients more than 24 hours on invasive ventilation, high risk of extubation failure, which means age higher than 65 years of age, past medical history of cardiac or pulmonary disease, and some other criteria. And they compared 2 strategies of 1-hour SBTs, either pressure support 8 or a TPs at 6 liters per minute. Weaning eligibility criteria, more or less the same as the JAMA trial I just presented. Please have a quick look at this. So PF ratio was higher than 150 at PEEP of 8 and an FU2 of 0.4. Primary outcome here was days alive without invasive mechanical ventilation from the first SBT, so more or less ventilator-free days. No significant difference between pressure support SBT or TPs SBT. Right here, percentage of patients with successful extubation after the first SBT. I think it's already a little bit better, right? In the first study that I just presented, it was like 93%. And right here, it's about 75%. So I think this is important. Again, if you do a screening test, you want to do it early. Otherwise, it doesn't have much of an additional value. But still think about this. Such a high rate of first SBT success. What does it tell us? Well, this is what the patients tell us. Right here, this is a very nice meta-analysis that shows the percentage of patients that needed re-intubation after a unplanned extubation. So self-extubation of the patient. And if you look right here, if in all these studies, on average, patients performed a self-extubation, only 50% of the patients required re-intubation. Which actually means that we as clinicians were too late in extubating the patient. The patient realized earlier that he was ready for extubation than we did. So this is important. This at least tells me that we may be late in extubation, or at least we may be late in conducting SBTs. So to conclude this part, I think SBTs are performed too late. And there's 2 arguments. One, in the studies, a very high percentage of SBTs are actually positive. And it doesn't make sense to do a screening test. And secondly, when there is unplanned extubation, only 50% of the patients require re-intubation. And now, well, in our wean safe study group, we were interested in a couple of things related to the weaning process. For instance, the differences in variation practices. I'm sure that quite a lot of you are aware of this study published a little bit more than 1 year ago in Lancet Respiratory Medicine, the so-called wean safe study. And the main aim of this study was to better understand the weaning process in a large real-world population of ICU patients that were on invasive ventilation for at least 2 calendar days. So among a lot of other things, we had to define our weaning criteria. What would we think was appropriate to perform the first SBT? We would say FiO2 below 0.5, at PEEP below 10, and low dose or no vasopressors below 0.2 micrograms per kilogram per minute. So in the whole WeanSafe study, more than 10,000 patients were included. As you can see, many centers from Europe, North America, Asia, and also quite a lot of patients were included from India. So for all the people that contributed, thank you very much for that. And this was the primary outcome. The percentage of patients successfully weaned at 90 days after inclusion. And this was actually quite shocking to us because it shows that from a global perspective, only 65% of the patients that are ventilated for more than 2 calendar days are successfully weaned after 90 days, which means that more than 30% of the patients actually die or remain ventilator bound after 3 months of mechanical ventilation. So I think this is a very important message here. Again, only 65% of the patients invasively ventilated for more than 2 days are successfully extubated and alive at day 90. Let us look a little bit more, based on the WeanSafe data, on the separation attempts. So what we found in this study was that an SBT was conducted in 66% of the patients, which there was quite some variation among countries, but worldwide, in 66% of the patients, an SBT is the first separation attempt. In other patients, 21% of the patients, there was no SBT but direct extubation. Again, this is in patients on the ventilator for more than 2 days. And in 14% of the patients, tracheostomy was the first separation attempt. An important clinical message is what are the risk factors for delayed weaning initiation. So you meet this weaning eligibility criteria, the PEEP, the FiO2, but you are not weaned. So what are the risk factors? As you can see here, patients that are frail are at risk for delayed weaning. Patients after trauma, neurological patients. But, and I think that's important, what we were interested in is the modifiable factors. I mean, we cannot change the fact that a patient is frail. But the modifiable factors, the modifiable risk factors for delayed initiation of weaning were the previous use of neuromuscular blockers, but most importantly, the use of sedation at the time of reaching this weaning eligibility criteria. And same thing, risk factors for failed weaning. So this means still being on the ventilator or death at 90 days. Again, the modifiable factors were sedation at the time of meeting weaning eligibility criteria, or when there was a delay between meeting the weaning eligibility criteria and performing the first separation attempt, the first SBT. So I think this is very important to realize here. So the key points that we got from this large WeanSafe study, first and again, weaning success at day 90 was only in 65% of the patients. And what are modifiable factors for delayed weaning or failed weaning is a delay between the presence of weaning eligibility criteria and the first SBT, and there is a very important role for sedation. Okay, so we discussed this in some detail, and what I take from this up to now is in my patients, every day during the rounds, when patient meets these criteria, PEEP is below 10, FiO2 is below 0.5, really consider performing an SBT. It's not a problem if it fails. It is a problem if it could be positive, but you're not performing an SBT, possibly resulting in too long duration of mechanical ventilation. So then an important point I would like to discuss is the failed SBT. I think it's important to realize when, especially if you're doing like the T pieces, that the transition from positive pressure ventilation on the ventilator to a negative intrapleural pressure during spontaneous breathing is really a challenge for patients' physiological reserve. And whether the patient is successful or not depends on the balance of the capacity and load imposed on the cardiopulmonary system and the respiratory muscles. So whether you're successful depends on, do you have an adequate respiratory drive, adequate respiratory muscle function, adequate oxygen transport, cardiac function, cognitive function, metabolic and endocrine function. And on the other hand, what is the load imposed on the system? And the load imposed on the system depends on many factors, but most importantly, respiratory resistance. Higher airway resistance results in a higher load on this cardiopulmonary system. Respiratory elasticity on compliance, intrinsic PEEP, gas exchange, oxygen consumption. So again, if there is a disbalance between the load and capacity of this system, an SBT will fail. And this is quite complex at the bedside, and that's why already many years ago we introduced this very simple algorithm which we called the ABC of weaning failure. So if a patient fails a spontaneous breathing trial, just consider, is there a problem in the airway? A. Is there a problem with brain function, cardiac function, diaphragm or other respiratory muscles, and endocrine metabolic function? And if you're interested, maybe you can read the paper, but I would highlight a few things, and especially a few novel things since we published the paper. I think in many ICUs now, and as I noticed from my friends in India as well, a lot of ICUs do have ultrasound available. And I think there's a very important role for ultrasound in the weaning process. If the patient fails a spontaneous breathing trial, to look at the airway, look at the, and I think there's a next slide, yeah, right here. So look at the airway. First check if there's obstructive pulmonary disease. Maybe this patient needs bronchodilation, steroids. Look at the chest wall. Is there still edema, low compliance? And also check the lung parenchyma. And checking the lung parenchyma can actually be easily done with ultrasound. As you see on the next slides, maybe there's B lines as an indication of fluid overload. Or is there pleural fluid? Or atelectasis with shunt fraction. Really easy to assess with ultrasound. So right here in this paper that we published in Intensive Care Medicine a few years ago, we discuss in detail the role of ultrasound during the weaning process. And I really think this is of high value in your clinical practice. And it's not too difficult to actually learn this. Okay, so we discussed the role of airway and lung in some detail during field weaning. But the second thing, and I briefly want to discuss, is brain dysfunction. I think a lot of you will realize that patients that are delirious are much more likely to fail a spontaneous breathing trial or fail extubation. And just one study to highlight. This is a nice study published a couple of years ago in JAMA that suggested in patients difficult to wean from the ventilator with agitation actually benefit from dexmedetomidine. And I think that's an important observation. To me, the important observation here is that if a patient is delirious, we need to treat it before the extubation. Otherwise, you are at high risk of failed weaning, failed extubation. And it's not just the dexmedetomidine. I think there's a lot of non-pharmacological interventions that can help you to treat delirium in these patients. Again, the transition from positive to negative pleural pressure does have a large impact on cardiac function. And if cardiac function has not sufficient physiological reserve, it may result in failed weaning. So this slide nicely summarizes the cardiac effects of negative intrathoracic pressure. So if intrathoracic pressure decreases, it will increase left ventricular afterload. This may result in increased left ventricular and diastolic pressure, result in the formation of pulmonary edema. Also, during a weaning process, adrenergic tone may increase, increasing left ventricular afterload, increasing systemic venous return, which in turn increases left ventricular preload, also resulting in pulmonary edema. And finally, I'm not going to discuss it in all detail, but the high work of breathing may result in myocardial ischemia, reducing left ventricular compliance, also facilitating the development of pulmonary edema. Again, in patients with limited cardiac reserve, it's important to realize that an SBT may result in development of pulmonary edema, resulting in hypoxemia and sensation of dyspnea. So how do we diagnose cardiac failure as a reason for SBT failure? Well, most simple. Actually, first thing to do is perform AKG at the start of the SBT or before the SBT and at the time that the patient fails. Sometimes you will see changes in ST segment consistent with cardiac ischemia during an SBT. If this happens, you know that the cardiac failure may play a role. Other things that you could do, and I think in the past, quite a lot of people would use the Swan-Ganz catheter, see an increase in wedge pressure is consistent with the increase in left ventricular and diastolic pressure, right? But very nice studies from the group of Paris have actually shown that measuring BNP or pro-BNP at the start and at the end of an SBT, a failed SBT, is helpful in diagnosing cardiac failure as a reason for SBT failure. So if BNP, pro-BNP increases by more than 12%, it has a reasonable sensitivity and specificity of diagnosing cardiac pulmonary edema. And more interestingly, actually, if you don't have BNP in your lab available, just look at the changes in hemoglobin. If hemoglobin increases during a failed SBT, it has a very good sensitivity and very high specificity in detecting pulmonary edema. Again, if a patient develops pulmonary edema due to cardiac dysfunction during an SBT, what will actually happen is fluid moves from the circulation into the lung. So what happens is hemoconcentration. So an increase in hemoglobin or an increase in protein during an SBT is a pretty sensitive and very specific marker of cardiac-induced reason for SBT failure. Very interesting. And again, we do this all the time, either this one or this one, and it's not requiring a lot of resources. And it has important consequences. I really love this study, published quite a long time ago, but I think it's important. I would love to highlight it now briefly. So these were patients with COPD and hypertension, but not a cardiac history. All patients failed at least three SBTs. What they did is extensive physiological measurements before and after nitroglycerin. So what did they do? So this was while patients were in their first SBT for the study. Again, they already failed 3 SBTs, but this was the first SBT for study purposes. As you can see, this is during mechanical ventilation. At the start and the end of the SBT, patients developed hypertension. So this systolic blood pressure on the ventilator was around 150 and increased to around 180 during the SBT, and arterial capillary wedge pressure increased from 15 to 23. On the next day, they repeated the SBT, but at that time they administered nitroglycerin intravenously just to target a systolic blood pressure below 140. And as you can see, they were successful. So at this second SBT, there was no increase in systolic blood pressure and no increase in pulmonary capillary wedge pressure. And most importantly, so on the first SBT, patients failed after 49 minutes, but on the second SBT, and just by administering nitroglycerin, 92% of the patients had a successful SBT and 88% of the patients had successful extubation. So just a simple intervention, administration of nitroglycerin did have a huge impact on weaning outcome. So this really stresses why it's important to diagnose cardiac failure, because it's so easy to treat, right? Okay, now let's move to the diaphragm, a very important reason, respiratory muscle failure, weakness for failing an SBT. So this is nice work, also from Paris, where they actually showed that respiratory muscle weakness is highly prevalent at the time of the first SBT. In fact, they showed that 63% of the patients met criteria for diaphragm dysfunction. And the interesting thing is that not all these patients, actually only 42% of these patients, also had peripheral muscle weakness. So, patients with respiratory muscle weakness do not necessarily develop peripheral muscle weakness, and the other way around, patients with peripheral muscle weakness are not necessarily developing weakness of the respiratory muscles. So this is important as well. Patients with prolonged weaning are much more likely, so patients with prolonged and difficult weaning are much more likely to have developed respiratory muscle weakness as compared to patients with simple weaning. So I think that respiratory muscle weakness plays a very important role in difficult weaning from mechanical ventilation. The pathophysiology is very complex, and we recently summarized that in this short paper published in the Blue Journal. But just to quickly summarize, so what is the pathophysiology of diaphragm weakness in ICU patients? Yes, there is a role for atrophy, just loss of muscle mass. But this is not as important as we may have thought a couple of years ago. I mean, animal studies will show you that atrophy is a very important contributor to respiratory muscle weakness during mechanical ventilation. With work from our own group, and we took biopsies of the diaphragm of ICU patients, it does show that atrophy is present, but it cannot explain the severe diaphragm weakness. So other factors are at play. Neuromuscular junction failure, neuropathy of the phrenic nerve, but very importantly as well, dysfunction of the remaining contractile proteins. So you lose part of your contractile proteins, atrophy, but the remaining contractile proteins are modified as well. They're less sensitive to calcium, but also there's inflammation in the diaphragm, there's fibrosis in the diaphragm. And what we have recently described, and I think it's a relevant finding, hibernation or stunning of the diaphragm. And a lot of you will recognize this from cardiac muscle during ischemia, where there is a period of stunning or hibernation of the myocardium. And we have now demonstrated and recently published that the diaphragm may develop hibernation as well. And that's actually described in this paper by Marloes van den Berg and Songhua Shi, published last year in Science Translational Medicine. It's a complex paper, but if you're interested, I invite you to read this one. Okay, let's get a little bit more practical for the last few minutes. How do we measure inspiratory muscle function in ventilated patients? Well, quite simple. If you have this kind of handheld devices, you just ask, you can connect it to the endotracheal tube or tracheostomy tube, and you ask the patients to take a deep breath. And high pressure, more than minus 40 centimeters of water, excludes severe weakness. And if you don't have these available, you can even do this on the ventilator, right? By performing an expiratory hold and ask the patient to take a very deep breath. As a kind of alternative, and that's what we described in this paper, ultrasound may be helpful. What you can actually do right here, so if a patient is on the ventilator, try to disconnect him and ask the patient to take a deep breath. Put the ultrasound below the costal arch, take the liver right here as a window. Right here you'll see the diaphragm, and ask the patient to take a deep breath. And during a breath, you will see movement of the diaphragm towards the probe. Another really deep breath. And then in the M mode, you can measure the movement of the diaphragm. And actually there is reference values for this. So for men during tidal breathing, it should be around 2 centimeters of water, and the maximum inspiration should be around 7 centimeters of water. The reference values are available from this. So how we use it? I mean, a patient difficult to wean, we just measure movement of the diaphragm. If the diaphragm does not move at all, an important contribution of diaphragm weakness may be present. The other thing you can do is actually assess thickening fraction of the diaphragm. So use the linear probe in the mid-axillary line. So you'll see the diaphragm right here. Between these two lines, this is actually the diaphragm. And if I start the video, you'll see that during inspiration, again, there's thickening of the muscle. From this, you can calculate a thickening fraction. The problem is there's quite some discussion about the reference values for this. We know it for healthy subjects, but it's a little bit more difficult in ICU patients. But how we use it in clinical practice is if there is clear thickening of the diaphragm during inspiration, respiratory muscle weakness seems unlikely. And we discussed this in a little bit more detail in the papers. This is important when a patient has important respiratory muscle weakness. Just realize that there is a differential diagnosis. Of course, most likely, this is critical illness associated diaphragm weakness, but other diseases could underlie this as well. Every now and then, the first presentation of these diseases are in the ICU. And then I realize I only have like 1 minute left. I just want to highlight this. I mean, in patients that have developed respiratory muscle weakness, we quite have some discussions what would be the appropriate therapy to improve respiratory muscle strength. And this is a study published already like 14 years ago that actually reported that inspiratory muscle strength training improves strength and increases the chances of success to be successfully weaned from the ventilator. However, this study is published last week in the Blue Journal, where they compared inspiratory muscle strength training to sham training in patients difficult to wean in the ICU. And I don't have the time to discuss this in detail, but honestly speaking, the bottom line of this paper is, right here, the bottom line of this paper is that there was no significant clinical benefits of inspiratory muscle training in patients difficult to wean from mechanical ventilation. There's a lot we can discuss about this, but I don't have the time, but I can highly recommend you to read the paper, especially if you are already using inspiratory muscle strength training in your clinical practice. This is more about expiratory muscle strength training. I'm going to skip this as well, but if you're interested in expiratory muscle strength training, you may want to read this paper. And that actually shows that inspiratory muscle strength training may maintain calf strength and expiratory muscle strength function in patients difficult to wean. But at this time, we're conducting a large international randomized controlled trial to show the benefit on clinical relevant outcomes. So to conclude, how do we improve weaning? I think I started to mention that it is actually very important to perform an early SBT. Identify the patients that are ready to be weaned. Look at the criteria that we suggested, and it's just a suggestion again, there's not a very strong evidence, but FA2 below 0.5, P below 10, consider performing an SBT. If the patient fails an SBT, think about a differential diagnosis. Why does the patient fail? Because if you reconnect to the ventilator and nothing changes, it's very likely you're not going to be successful the next day. And this has important implications because we can treat cardiac disease. Maybe we can treat respiratory muscle function. And we didn't have really time to discuss it, but don't forget treatment of dyspnea sensation in these patients. So thank you very much for your attention, and I'm happy to take questions from here.
Thank you, Professor Heunks. That was very nice listening to the insights from the leading expert on weaning in the world. You have done so much work, and it's a pleasure to hear that. So, sir, while we wait for any questions from the audience, maybe I can just put up a few points for discussion. So, sir, coming to the weaning method, TPs versus pressure support ventilation. So, would you like to comment on that, sir?
Yes. In my practice, actually, I would prefer the TPs above pressure support. And there's another reason for that, which I did not really have the time to discuss into detail. Actually, physiological studies demonstrate that the work of breathing after extubation is most comparable to breathing effort during an SBT. So during a pressure support, you're making it a little bit more easier for the patient as the situation after extubation. So what we do in our ICU, we keep the patients on the ventilator, but just reduce PEEP and inspiratory support to 0. So that's how we do it in our ICU. And I think that is, well, what the New England trial suggested would be reasonable. And I think it's reasonable from the perspective of the underlying physiology.
Right, sir. Thank you. So then coming to failed weaning attempts. After a couple of failed weaning attempts, is there a best strategy, or is it the same, just put a TPs and hope for the best? And like you said, look at causes for weaning failure and try to rectify them.
Yeah, I think that's a great question. Thank you. I think the most important thing is do some diagnostics. So take an arterial blood sample before and at the time the patient fails. Identify did this patient become hypercapnic or not. If this patient became hypercapnic, and pulmonary or respiratory muscle origin is much more likely. If he did not develop that, just look at changes in hemoglobin or proBNP if you have it available. And again, use the ultrasound if you do have it available. If there is pleural fluid, if there is B lines consistent with fluid overload, look at the function of the diaphragm. I think that is a really important point. You want to understand why the patient fails, right?
Right, sir. Thank you, sir. So, sir, moving on to the question of prolonged weaning trials. Though it has been suggested in literature, certain patients, like those who have undergone prolonged ventilation for 3 weeks or who have failed more than 3 attempts, or neurology patients who are difficult to wean. Is there a role for prolonged weaning for 24 hours on TPs or pressure support?
Yeah, that's that's a great question as well. So you're referring to the prolonged spontaneous breathing trials, right?
Yes, sir.
That's right. If the patient, that's how we do it in the ICU, and I think that's indeed a reasonable approach. If the patient fails SBT and you're not comfortable in extubating the patient, what we do is just prolong the SBTs from 1 hour, 2 hours, 3 hours, and then incremental increase in SBT. But typically the patient then is tracheostomized, right? I mean, it's a very different topic. What would be the appropriate timing to tracheostomize the patient? But I think it is reasonable if weaning is indeed it is difficult, and you're thinking about doing this prolonged SBTs, that this would be best done while the patient has tracheostomy, and then we have this kind of more or less fixed scheduled where we increment the duration of the SBTs.
Right. So thank you, sir. So then moving on to COPD. So patients with acute exacerbation of COPD, and typically it's said after 48 hours, you can generally, put them, you can extubate them and put them on NIV. But there is a certain subset, sir, who are not extubatable, as we all know, who require prolonged ventilation. So how do we decide, hey, sir, those who are going to stay on the ventilator and not be extubated to, NIV after 48 hours of mechanical ventilation?
That's an excellent question as well. Yes, I think there's quite some evidence, right? For instance, the Venice trial published in the Blue Journal a couple of years ago, as you suggest, even if the patients with acute exacerbation of COPD fail an SBT, you may want to extubate and perform the further weaning with non-invasive ventilation. And actually does not reduce the total time the patient is on the ventilator, but it does reduce the time the patient is on invasive ventilation. So I would say in our ICU, we would say if a patient is already familiar with non-invasive ventilation and the patient is actually able to be on NIV for quite a number of hours a day, we would go for the strategy extubate and perform the further weaning process on NIV. However, if we knew that some of the patients are difficult, cannot stand the NIV mask for a long time because they got agitated, they got anxious, then in these patients we would early tracheostomize them, and we would do the weaning process with invasive mechanical ventilation. So honestly speaking, I do not have very good data to suggest which patients should be on weaning using NIV and which patients on invasive ventilation. To me, it's, if possible, it's in a discussion with the patient. So if the patient is comfortable in doing this weaning process on NIV, we would do it that way. If not, you could still give it a chance and accept the reintubation, right?
Right.
But it's important that at least the Venice trial did not show that it resulted in early ICU discharge.
Thank you for the answer, sir. So then again, neurology patients, many patients in neurology, neurocritical area do not regain full consciousness and they remain obtunded and they have weakened reflexes, etc. And as far as I know, sir, there is no criteria laid down for extubation in neurology patients. And of course, some are tracheostomized, some are not tracheostomized. More importantly, those who are not tracheostomized, I want to know, sir, is there any criteria for deciding between extubation and going ahead with tracheostomy in these neurology patients who are not fully recovered neurology and remain obtunded?
No, that's an excellent question. And I did not highlight it in this talk, but obviously there's data to suggest that an SBT is not of that much value in neurological patients, right? I mean, you're testing something that is not really the problem in these patients. You're most concerned, as you outline, about their level of consciousness and their ability to cough. I mean, that's not something that you are actually testing in with an SBT. So I think there's nice data out there to show that the SBT has limited value in neurological patients. So then I would say the most important thing is decide whether this patient has an adequate cough or not. If the cough is adequate, I think it's reassuring that the patient can be extubated even if the EMV score is low. Otherwise, I would be very hesitant. And I remember, but honestly speaking, I did not read the paper yet. There is a very nice paper by Chiara Roba, from Genoa in Italy about weaning in neurological patients. So maybe we need to refer to that paper for this specific question. But in my practice, first it's important to understand that there's a very limited role of an SBT, and it's more like the decision, do we expect that the patient has sufficient reflexes for adequate coughing after extubation? Would you agree on that, sir?
Yeah. Please carry on, sir, if you're not finished. Thank you, sir, for the answer. So then, when you are putting the patient on the TPs and, trying to wean off the patient, give a SBT, start a SBT, some of the patients become anxious and anxiety, the respiratory rate goes up. And also the tidal volume goes up, I believe, in these patients. Is that correct, sir? Or some of the patients will develop a low tidal volume also with a high respiratory rate when they get anxious? Because if they have a high tidal volume and a high respiratory rate, because of anxiety, are they extubatable? So your comments on this anxiety and SBTs.
Yeah, so that's an interesting question indeed. So I think the problem is if the patient really gets anxious during the SBT and even independent from the respiratory response, the first thing is very important to understand, why does this patient become anxious in the first place, right? And an important underlying reason could be sensation of dyspnea. If the patient feels a shortness of breath, which is actually highly prevalent in patients on mechanical ventilation. There's a very nice paper by Martin Tobin's group in the Blue Journal this week. And there is some couple of nice papers on dyspnea during mechanical ventilation from the group by Alexander de Mou, also in the Blue Journal. And you can imagine that if you're reducing inspiratory support, you're removing PEEP during an SBT, the patient becomes dyspneic, but cannot communicate, cannot express that being anxious is a normal response, right? So I think if the patient becomes agitated, anxious, our first thing to do is understand why. Is this related to dyspnea sensation? Is it something else? So apart from respiratory rate or tidal volume. So maybe there's something else that we could do. Or is the patient just in a period that you think, well, because the patient is awake now, he's anxious because of the endotracheal tube, we just extubate and see what happens. But if it's related to dyspnea, we have to understand why this patient becomes dyspneic. So I think your question is great. So how does a larger or a smaller tidal volume affect your decision making? Yeah. But from my clinical practice, from my perspective, I would say the most important thing is understand why the patient has become anxious. Is this delirium? Maybe we need to treat the delirium as suggested by the study I mentioned, the Dahlia trial. Maybe dexmedetomidine plays a role. But if this is related to dyspnea, obviously we need other interventions to relieve dyspnea, right?
Thank you for the answer, sir. So now just a final question, sir. Sir, when we are having failed SBT and a couple of failed attempts, or even just a single attempt, is there always an identified factor, or is there something unidentifiable also just between the interaction between the patient and the respiratory system of the patient? Is there something like this?
Yeah, it's a very good question. I mean, the issue is, and maybe our schedule, the ABC schedule, try to simplify it a little bit too much, because actually the problem is in quite some patients, it's not just one issue. It's not only just cardiac failure. I mean, diastolic dysfunction. But what we see quite often, it's a little bit of diastolic dysfunction. It is a little bit of respiratory muscle weakness. It's an interplay between different factors. But still then, go back to the initial figure I showed you, the balance between load and capacity of this respiratory system. Still, in these patients, it would make sense. See if you can get rid of pulmonary edema. If you can get rid of edema of the chest wall in itself, can you prevent hypertension? If you cannot identify one clear factor, it's like how we would call it, putting the dots on the I. Make everything perfect for the patient to be able to pass the SBT. Again, it is, you could say on one hand, it's not easy to find a factor. In my practice, what I see often, it's a little bit of this, a little bit of that. And it's just because there is a disbalance between the load and capacity, which makes it difficult for the patient to wean. So you have to do a couple of things at the same time, and then very often it will work. But I think the worst thing you can do is not consider, not think about the reasons, not having a differential diagnosis why the patient cannot be weaned. Because I mean, you're trying it the next day and the next day, and nothing improves, right?
Right, sir. Thank you, sir. Professor Heunks, sir. Wonderful listening to some of the greatest stuff in weaning. We're really honored, and we had a wonderful audience. I thank the audience. I think they have learned a lot, and it was a treat actually. And soon we will put this up on our YouTube channel for the global community of intensivists to look at and to learn from. Thank you so much, sir, for a class on weaning. Thank you so much.
Thank you so much for the invitation again. Have a nice day.
Bye-bye, sir.
Bye-bye.